The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast, where we navigate the maze of healthcare policy and economics each week. My name is Marc Ryan, and thanks to everyone for listening in. This week's episode is the fourth of 5 installments in our healthcare reform series at the Healthcare Labyrinth Podcast. It is titled America's Healthcare Grand Bargain, Affordable Universal Access, the third pillar of American healthcare reform. If you've been following along, you know this series is built around 3 core tenets. First, price reform. Second, shifting from utilization management to true care management in primary care. And third, today's focus, affordable universal access. I first laid out this framework in 2024 as the presidential campaign was heating up. I've re-recorded and updated it for the 26 midterms because the underlying challenges in American healthcare have not gone away. They've actually intensified, and reform is even more needed today. You can also find the companion writings for this series at the Healthcare Labyrinth blog site. They were published on May 26th, May 28th, June 4, and June 12. That's healthcarelabyrinth.com. Much of this thinking also comes from my book, The Healthcare Labyrinth, available in print, ebook, and audiobook formats through major booksellers. So let's get into it. We'll take our usual 3 breaks today. So part 1, the core problem, America confuses coverage with access. One of the biggest misconceptions in American healthcare policy is the assumption that coverage equals access. It does not. Coverage simply means you're enrolled in a plan. Access means you can actually afford and use care when you need it. Those are not the same thing by any means. A patient with a $6,000 deductible technically has coverage, but if they cannot afford to meet that deductible, then for practical purposes, they do not have access to care. A patient with a narrow network technically has coverage, but if the nearest in-network specialist has a 6-month wait list, access is constrained. A patient with high coinsurance technically has coverage, but they may delay care due to cost exposure. So when we talk about universal coverage in the United States, we often miss the deeper question: do people actually have affordable access to care when they need it? That is the real issue. Part 2, the underinsured problem is the real crisis. Much of the political debate focuses on the uninsured population. That is a problem. We have between 8% and 10% consistently uninsured today. That's around 30 million people. But the larger structural issue is the underinsured population. These are individuals who have insurance on paper, but face significant financial barriers when they attempt to use it. This includes high premiums that families struggle to pay and erode other needed cash for healthcare expenses, high deductible health plans, high coinsurance structures, rising premium contributions, out-of-network exposure, specialty drug cost sharing, and fragmented benefit designs. The result is a system where people are technically covered, but functionally exposed. And that exposure changes behavior. People delay care, skip medications, avoid specialist visits, postpone diagnostics, even if some of them are free under new laws, and ultimately present later with more advanced and more expensive conditions. So ironically, underinsurance does not reduce system cost. It often increases it. With that, we will take our first break, and when we come back, we will continue down the road of discussing affordable universal access. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage and a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back to the Healthcare Labyrinth Podcast. I am Marc Ryan, and we hope you are enjoying this episode. We are in episode 4 of our 5-part series on healthcare reform and are discussing affordable universal access. So part 3, what universal access actually means. Let me define what I mean by affordable universal access, because this term is often misunderstood. I'm not talking about socialized medicine. I'm not talking about single payer. I am not talking about Medicare for all. And I am not talking about eliminating private insurance. Affordable universal access means 3 things. 1, everyone has a defined pathway to coverage, not necessarily one system, but no gaps between systems. Employer coverage, public programs, and individual markets must connect seamlessly. 2, financial protection is real, not theoretically. Coverage must meaningfully protect individuals from catastrophic medical costs and encourage the use of primary care and prevention, not just in statute, but in practice at the point of care. 3, affordability is preserved across life transitions. People should not lose access because they change jobs, lose jobs, age into Medicare, move states, or experience income volatility. In short, access should be stable even when life is not. Part 4, why the current system fails. The United States does not fail because it lacks programs. It fails because it lacks integration. We have employer-sponsored insurance as the dominant base, Medicare as the senior coverage system, Medicaid as the low-income safety net, ACA exchanges as the individual market for others who do not have consistent access to health insurance, and various supplemental programs layered on top. Each of these systems works within its own boundaries, but the transitions between them are where problems occur. People fall through eligibility gaps. Coverage resets create disruption. Subsidy cliffs distort behavior. And administrative churn creates inefficiency. So instead of a unified access system, we have a patchwork of partially connected systems. Part 5, employer coverage, strong but incomplete. Employer-sponsored insurance is often described as the backbone of the system, and it is, but it was never designed to be a universal access solution. It is employment-linked, variable in generosity, dependent on labor market stability, and uneven across employers. Large employers often provide robust coverage. Small employers often do not. Part-time workers may receive no coverage at all, or it is so expensive people opt out. And job transitions create coverage instability. So while employer coverage is a strength, it is not sufficient as a standalone universal access mechanism. Part 6, the safety net, too, is fragmented. Medicaid and Medicare serve as critical pillars of the system, but between them lies a structurally vulnerable population. Near poor households, gig workers, individuals with intermittent employment, early retirees, and those cycling between eligibility categories. This group often does not fit cleanly into any program. The exchanges are meant to compensate, but plans there have become so expensive, even with subsidies, that many avoid enrolling. And as a result, they experience the greatest instability in access, not because the programs fail individually, but because the system does not connect them effectively. With that, we will take our second break, and when we come back, we will continue down the road of discussing affordable universal access. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back to the Healthcare Labyrinth Podcast. I am Marc Ryan, and we hope you are enjoying this episode. We are in episode 4 of our 5-part series on healthcare reform and are discussing affordable universal access. So part 7, the solution, structured universal access, not single payer. A key point I want to emphasize, affordable universal access does not require a single payer system. It does not require government-run healthcare, and it does not require eliminating private insurance. Instead, it requires structure, a coherent national framework where private insurance continues to play a central role, one or more public programs fill defined gaps, and transitions between systems are seamless. The goal is not uniformity, the goal is continuity. Part 8, subsidies must follow people, not programs. One of the biggest inefficiencies in the current system is how subsidies are fragmented. We subsidize employer coverage indirectly through tax exclusions, Medicaid through federal state matching and state matching, exchange plans through premium tax credits, and various supplemental programs separately. But these subsidies do not always move smoothly with individuals. A better system would align subsidies with people directly, not with their employer, not with their program category, but with their actual income and need. That creates stability and reduces coverage churn. Part 9, why this matters for cost and quality. Affordable universal access is not just a moral or political argument. It is also an economic one. When people have stable access to care, they seek treatment earlier, chronic conditions are better managed, emergency utilization decreases, and downstream costs decline. When access is unstable, care is delayed, conditions worsen, and costs rise throughout the system to compensate. So paradoxically, expanding access can reduce long-term system costs, not immediately, but structurally over time. Part 10, the big misunderstanding in the debate. American healthcare debates often become polarized around two extremes: full market-based systems or fully government-run systems. But that framing misses the reality of many developed systems. Many countries operate private delivery systems, regulated insurance markets, and structured public financing for universal access that is affordable. The question is not whether government or market should dominate. It is how they should interact. With that, we will take our last break, and when we come back, I will get to my concrete proposal on affordable universal access. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back to the Healthcare Labyrinth Podcast. I am Marc Ryan, and we hope you are enjoying this episode. We are in episode 4 of our 5-part series on healthcare reform and are discussing affordable universal access. So part 11, what would I propose to solve the issue of affordable universal access? Given private delivery success in other developed nations, I propose that the United States adopt a system rooted in private affordable universal access. Private plans would run the healthcare system with regulatory direction, from the Centers for Medicare and Medicaid Services and other state and federal agencies. I think CMS should take the lead in most areas to ensure coordination across what would be a few lines of business. While a burden on business, I believe we should continue with our employer-sponsored coverage foundation. There are a few reasons. As I noted in the price reform blog, price reform would help reduce costs for businesses and end cost shifting to employer coverage. That would also make coverage more affordable. Employer coverage is also reasonably popular among Americans. Last, ripping employer coverage apart would mean huge upheaval in the system as a whole. The problem is that there's a solid percentage of Americans, I round it to about 25%, to cover both the uninsured and underinsured, that do not have a consistent or strong nexus to employer coverage or do not have affordable coverage. There are some elderly and disabled that are uncovered and do not work. Some go in and out of the job market. Some have low incomes and cannot afford premiums and cost sharing. As such, I propose that we create one master safety net healthcare program that serves these folks. The system would have sliding scale premium and cost sharing subsidies. For lower income families, the subsidies could be used either for employer coverage or the safety net program. I am open to maintaining the Medicare program side by side with this system given the sicker cohort the program serves and its complexity. But a case could be made that the single social safety net program would be most stable with all remaining non-employer populations in it. The one master social safety net program could be sponsored by the federal government or be a state-federal partnership like Medicaid and some exchanges. The traditional fee-for-service Medicaid and Medicare systems would go away in favor of a private delivery model as we have in Medicaid managed care and Medicare Advantage today. If Medicare remained freestanding, I think the traditional system should likely go away anyway. Most Affordable Care Act protections would stay in place, including community rating, pre-existing condition protections, preventive services, and benefit mandates. I propose to modify the generosity of some of the benefit mandates. In more rural areas, rate-based participation incentives similar to what is in MA today, as well as reinsurance and rate corridor programs like occurred in the exchanges in the beginning, would be put in place. Fair risk adjustment rates would also be a cornerstone. If Medicare remained freestanding, additional participation incentives could be passed to further increase MA penetration to cover all Americans throughout the country with good choices. Employer and individual mandates would exist. Tax credits for small businesses would also be available and be expanded. What would be accomplished if my proposal is adopted? We finally would have affordable universal access that prioritizes coverage. Coverage will eventually reduce costs in the system as people move to less costly healthcare interventions as opposed to crisis inpatient and emergency room services. We would conquer the issue of the uninsured, but also of the underinsured. Combined, these total at least 85 million Americans, or again, about 25% of the population. We would eliminate tremendous duplication and administrative costs in the healthcare system. Today, this costs billions of dollars per year. My proposals on price reform could be more easily implemented. With better and more stable coverage for all, the shift from utilization to care management could be successful. Sound familiar? Some of the proposals mirror various historic proposals, including Romney Care, Hillary Care, and Obamacare. But the proposal has most in common with the proposal by President Richard Nixon back in the 1970s. You could say I cribbed a bit from Nixon here. Nixon was somewhat of a trailblazer on healthcare, including supporting and ushering in the HMO Act of 1973, as well as Nixon's Universal Healthcare Access proposal in early 1974. He had proposed a partial remake as well in 1971, which would have mandated employers provide health insurance and started federal affordability subsidies for workers. Nixon resigned during the Watergate scandal in August of 1974, killing any chances for his second plan to pass. What I find fascinating about Nixon's healthcare proposal is his compassion for the less fortunate, which is not unlike that of another Republican president, Teddy Roosevelt, who also proposed universal healthcare access in his 1912 run as the third-party bull moose progressive candidate. Part 12, looking ahead. In our final episode, we will bring everything together. We will take price reform, care transformation, and affordable universal access and combine them into a single coherent framework, the healthcare grand bargain, a uniquely American model that preserves private delivery, strengthens public accountability, and finally aligns incentives across the system. That is where we go next. That's it for today's episode of the Healthcare Labyrinth Podcast. Thanks for listening. If you enjoyed today's episode, be sure to subscribe and share it with colleagues interested in healthcare policy. You can also read the companion articles on the Healthcare Labyrinth blog site, along with the other installments in this series, published on May 26, May 28, June 4, and June 12. And if you want to go deeper, my book, The Healthcare Labyrinth, is available in print, ebook, and audiobook formats through major booksellers and at healthcarelabyrinth.com. Until next time, stay curious, stay skeptical, and keep navigating the healthcare labyrinth with me. We will find our way out together. Again, I am Marc Ryan. This is the Healthcare Labyrinth Podcast. See you next week. Take care.
Thanks for joining Marc and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.